This is the bifurcation of the ACA. So this is the pericallosal artery which runs above the corpus callosum, and this is the callosomarginal artery which runs across the cingulate sulcus. So approaches to the anterior cerebral artery aneurysms. So here the intrahemispheric approach is the most preferred one. So to do that, we need to have the subdural dissection. So this is the subdural dissection, and then you will have the subarachnoid dissection. The length of the subdural and the subarachnoid dissections varies from anterior to posterior. Because if you see here, the thickness of the falls, this is the falls cerebrae. Okay, the thickness of the falls increases from anterior to posterior. So when the thickness increases, the subdural dissection, the length of the subdural dissection will be more when you extend from anterior to posterior. The vice versa, the length of the dissection, subarachnoid dissection, will be less when you extend from anterior to posterior. So this is mainly because of the thickness of the falls cerebrae when you move from anterior to the posterior. So we divide the anterior cerebral artery aneurysms or the pericallosal artery aneurysms into proximal, middle, and distal. Okay, this is a proximal, middle, and distal. So the low dissection, so for approaching the proximal and the middle pericallosal artery aneurysm, the patient can be maintained in neutral position. The positioning for the surgery is maintained in neutral position. Whereas for the distal AC aneurysms or the DACA aneurysms, it is preferred to position the patient in lateral position so that the gravity helps in the retraction. Rather than putting the static retractors, this position aids in the gravity aids in the retraction. So the position itself will help us in doing the dissection. So the ipsilateral, if you have a right DACA aneurysm, the patient is turned towards the left. So the patient is turned towards the right. So that in the right side, the brain will fall down and the gravity helps in the retraction and the dissection will be comfortable. So the various steps. So again, as said in the MCA, follow the cortical vessel. So here, once we do the craniotomy and durotomy, follow the cortical vessel. So follow the peripheral arteries deeper and deeper and split the anterior interhemispheric fissure. Okay, it is important that we follow the peripheral arteries deeper and deeper. So once you reach deeper, widen the fissure split by following the pericallosal artery. So once you come here, follow the pericallosal artery along the corpus callosum. Okay, follow the pericallosal artery along the corpus callosum. And then shift the dissection proximal side. So you have to come proximal to the aneurysm. So if it is a low-lying or a proximal pericallosal artery aneurysm, they require a dissection trajectory almost along the floor of the anterior cranial fossa. Okay, whereas if it is a high-riding or a middle pericallosal artery aneurysm, the proximal control is quite easy. And similarly for the DACA aneurysm, the distal AC aneurysm, the proximal control can be easily obtained with the interhemispheric transcallosal approaches. So then, prepare the, once you finish the subdural and the arachnoid, subarachnoid dissections, and follow the peripheral artery deeper into the pericallosal artery over above the corpus callosum. Prepare the afferent artery for proximal control. This is the afferent artery of the proximal control. And then identify the contralateral ACA and then the contralateral callosomarginal artery. And then you have to expose the efferent artery, the efferent callosomarginal artery. And then again the ipsilateral or the the contralateral pericallosal artery, and then identify the efferent pericallosal artery. So once all these vessels are clearly dissected out, then the cleavage can be obtained over the aneurysms. So identifying the 6 major vessels dissection is vital here at this point. The 6 major vessel means that is the efferent, afferent artery, that is the ACA, that is the A3 ACA, and the contralateral So in 1 minute, this gets completed. So if it gets over, I shall continue in the next Sunday, this pericallosal artery aneurysms alone, and then I'll get back to the spine. So the contralateral callosomarginal artery, the contralateral pericallosal artery, the ipsilateral callosomarginal artery, and the ipsilateral pericallosal artery. So all these 6 vessels need to be exposed to approach for such aneurysms at this area. So the types of clipping to be used here is tandem clipping, fenestrated clips, and the intersecting clips. The tandem clips is mainly for the proximal pericallosal artery aneurysms. The fenestrated clips mainly for the middle pericallosal artery aneurysm, and the intersecting clips mainly for the distal, the dark aneurysms, the distal ACA aneurysms. The tandem clips for the proximal, the fenestrated clips for the middle pericallosal.